I guess we're going to get started then. Hi, everyone. I'm Margaret Cox. I am a dermatologist at the University of Utah, where I subspecialize in vulvar dermatology.
And I am Kylie Moss. I'm a gynecologist at the Centers for Vulvovaginal Disorders in Washington, D.C., where I specialize in conditions that cause pain with sex and other vulvovaginal skin conditions.
So this podcast, it's going to be a dialogue between me and Kylie talking about vulvas, vulvar disease, all things vulva, 100% vulva, maybe some vagina, because you can kind of throw in some good
Yeah,
vagina tidbits. And I
hard to keep it out
Hard
completely.
to keep it out. I mean,
Yeah.
they're very related. So there
Yes.
will be some vagina, I think. And I got interested in vulvar dermatology really way back when, probably back when I was a grad student. But then I did pathology residency and I did a lot of research in vulvar squamous cell carcinoma and genital cancers. And then I completed a second residency in dermatology where I found that this was an area that was very neglected within dermatology and actually within medicine more broadly, I think, and found it very satisfying to take care of patients who presented with vulvar disease. And now I have one clinic day a week where I just treat vulvar disease, and it has really become a passion of mine.
It's amazing. Yeah, I mean, I got in this because I was a patient way back in the day, and because of that, got um, introduced to some folks at my medical school who were working in this area, and did a case report with them, and then went on to residency in OBGYN because I knew I wanted to do women's health, but there wasn't a lot going on in terms of specific vulvovaginal research when I was in training. And I think also just like in training, you get into like put one step in front of the other, keep, learn all of the basics of your specialty. And so I kind of got away from it, although I was doing pain research and research in like opioids after gynecologic surgery. And then I went to Hopkins for, 5 years or so, was still doing more of that work along with research in patients that have abnormal pap smears. But this had always sort of been in the back of my mind. And Dr. Goldstein needed someone. And I had heard that through a friend who knew him. And I
So who's
went
wait?
sort
Who's
of went
Dr.
to New York to
Goldstein?
see what he was. Oh, yeah, sorry. Andrew Goldstein, my partner, who is, yeah, nobody knows any of this
Nobody
stuff,
knows who that guy is.
who is uh, sort of, I would say, the senior partner at the Centers for Vulvovaginal Disorders. And he has done a ton, decades of amazing research in vulvovaginal in this space. And so he's, had me come up to New York. And so I hung out with him there. I hung out a little bit with Jill Kraft at the DC office where she was at the time. And it turned out that she was leaving and going to start the Florida practice. And he really needed someone in DC. And so I sort of hopped aboard and now I'm here.
Awesome.
Yeah.
Perfect.
Yeah.
So we are kind
Yeah.
of on opposite coasts right now,
Yeah.
and we are offering a dermatology perspective and a gynecology perspective on
Yeah.
vulvar disease, just vulvar things in general.
Yep.
And I think one of the visions for this podcast was um, really starting the conversation about vulvar disease and just vulvas in general. Am I right? Yeah.
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 I mean, I don't know about you, but like I didn't learn this terminology until well into residency. Like
Yeah.
even I don't think that, I mean, maybe there was some coverage in anatomy class, but the vagina monologues, amazing and groundbreaking as it was,
Hmm.
use that terminology. And I feel like I have come to learn that the like thinking about the vagina, which is really just a hollow tube between the uterus and the vulva, it has amazing function, but is not as complex and is not as contributory towards sexual function as the vulva. And so
Absolutely.
we just want to be like centering function and sexual function. I feel like in our name. Yeah.
Yeah. So um, I think there's a lot of increased conversation, dialogue about vulvas, but I feel like it is still quite a taboo topic.
Yes.
And people don't like talking about it from a medical perspective, although there's a lot of chatter in kind of pop culture more broadly. And so one of the things I wanted us to dive right into what we were going to talk about, because I
Yeah.
kind of keep my eye on what's going on in pop culture, because patients come to you and they ask you questions, or you're scrolling through Instagram or TikTok and like something absolutely ridiculous comes through your feed and you're like, what are people talking about? One of the things I saw recently, this was this fall, was something called labia puffing. And now, full disclosure, as a dermatologist, I am a medical dermatologist, so I don't do a lot of cosmetic dermatology. We definitely do cosmetic dermatology in training, and we do a lot of filler, like in the lips, in the cheekbones. But labial filler never came across my radar prior to me reading this Allure article that came out in November of 2024, um, which was called "Why Are Women Getting Their Labia Puffed?" Have you heard about this, Kylie?
So I heard about it from you, which is because I'm like a pop culture idiot and live in a cave with my children and like don't know
Yeah.
what's going on. Now I will say I think the corollary to this is that over TikTok, like it's been we've had a lot of questions about labial resorption lately.
Yes. Right.
And so I feel like the background is that people have all of a sudden become very concerned about changes that happen to the vulva with age.
Mm-hmm.
And it's absolutely true that under the influence of estrogen, people are born with two X chromosomes and have like sort of typical vulva, have very minimal labia when they don't have a lot of estrogen in infancy. Like if you're ever changing a little girl's diaper, there's really not much there in terms of labia minora or prominence of the labia. And then as puberty happens, the labia become more prominent. But it's also true that when you take estrogen away in menopause or perimenopause, that the labia become less prominent again. And certainly when I'm examining someone who's in menopause, maybe 10, 20 years out for menopause, their labia are usually on average less prominent
Mm-hmm.
than people who are younger. And so I think it's part of this like anti-aging. But I'm interested just for like the general public, like, so what is filler? Can you tell me a little bit more about what filler exactly is?
Yeah. So the filler that most people use for like lips on the face,
Yes.
usually they're using hyaluronic acid. So this is a component of the skin that is there normally, and it's kind of like a water attracting protein that
Hmm.
gives you the appearance of fuller, more supple skin. And as
Got
we
it.
age, not only so like there's definitely estrogen component. We're talking about the vagina, vulva, skin in general, but
Yeah.
just all around aging, there's loss of collagen and loss of hyaluronic acid and gravity and sagging that happens with the face and,
Sure.
yeah, with the genitals to a certain extent as well. So, in order to restore that plumpness or to achieve that aesthetic look that you find attractive, that makes you happy, you can inject filler into the soft tissue of the body. In the labial puffing, they mostly talk about hyaluronic acid, which is actually, it's a nice filler because if you screw it up, you can dissolve it with
Oh,
hyaluronidase. So that's like another injectable that you use to break down the hyaluronic acid, and then you can
got
like
it.
fix
So
what
like if
you
you go too far
if
in
you
someone's lips, you
overfill.
can go
Yeah,
back.
you can
You can dial
dissolve
it back.
it, and not all of the other fillers offer that option. Um, has this been studied specifically in the vulvar skin? So mostly they're talking about filling the labia majora here.
Uh-huh.
No, although in this Allure article, I thought the Allure article was pretty well written, and they did provide links to two um, papers, studies that looked at this. So there was like a review that they looked at here, and then just
Hmm.
another kind of also review. But what I
Yeah.
found interesting is that a lot of the time these people also had, and again, I always find this a difficult conversation to have with my patients. They had what I guess would be considered as large labia minora. So a lot of the time
Mm.
they actually also
So
did,
it's like a relative issue.
yeah, so in these papers they would do a labiaplasty to reduce the labia minora, and then they would do labial filler on the labia majora.
Ah, I
So
see.
it was kind of like, well, I don't know how useful this paper is because you're not just doing the labial filler in the majority of these patients because there's other things that they're concerned about.
Right.
In terms of safety profile, again, I feel like the hyaluronic acid is fairly safe. It doesn't last forever. It can dissolve, although there's been some recent studies that have shown hyaluronic acid staying in the skin for a very long time, usually with like
Oh,
imaging.
oh,
Some of the other things they talk about in this Allure article are an autologous fat transfer. So you take fat from like
right.
your butt or your belly, and then you put it into the
Yeah,
labia, um, which that I think has a less predictable cosmetic final product because
right.
you don't really know
Because
how much
can
of
you
that.
get
Right.
like sclerosis around the fat and like sort of unpredictable to like sort of terrain? I don't know
Yeah,
what
so
the like
most commonly
topography.
what you can get with even with hyaluronic acid or with the fat is you can get granulomas formed. So that's just a type of inflammatory response to a foreign body. Less probably so with the autologous fat transfer because you are injecting your own fat back into your body. But if you're
Right.
using like a foreign protein, then your body can recognize that as foreign and then kind of encapsulate that with granulomas, and then that becomes a little more difficult to treat.
Yeah.
Um, but I think the bigger question here is, and you touched on this, right? Like, so when you're, and most of the people they talk to in this article are in their 40s or higher. These are people who are in perimenopause,
Right.
menopause, postmenopausal. There is a change in the way the vulva looks here. Is there is, and then there is somewhat of a change in terms of functionality. No, I don't think
Um,
so much so with the labia majora and the puffing, but maybe just with general estrogen lowering.
Yeah, I mean, I think estrogen is tremendously important, and I always liken it to like, okay, I turned 40, I needed glasses. I never needed glasses before I turned 40, and it's because my eyesight changed when I aged, and I no longer had the functional capacity I did before. And
Hmm.
so when I'm talking to people about estrogen, I
Yeah,
say like, listen, it goes away, and it was really useful to you, and you're probably better off if you have it. But in terms of the appearance, I'm just not as convinced. Like, I
yeah,
think
exactly.
I because of this and like thinking about this podcast, I looked into like what is the evolutionary function of the labia minora and majora, and I don't think there's been like a ton of study about it. Like, what animals have any kind of preservation of these skin folds around the vagina that are on
Yeah,
the outside? Like, um, and I think they probably like in my just like in what I've seen, I think they probably provide some sort like mechanical barrier to stress and friction,
hmm,
and they also probably protect like are a mechanical barrier to keep things out of the vagina that you don't want, right? Like
yeah,
but I'm just not, I feel like there are, we see people with like in sclerosis that don't have much in the way of labia minora and majora, and if we have their skin disease under control, they tend to do fine from a sexual function standpoint. So I'm just not convinced this is like something you need functionally. Like estrogen to make the vestibule lubricated and to
right,
not have pain
right,
with sex feels very important. Or,
yeah,
some other product, hyaluronic acid, it can be used in the vestibule to help, and it works really
right,
well too for people who can't use hormones. But I just think from, I have a hard time. I'm like a real hippie at heart. I have a really hard time with things that are potentially harmful,
right,
purely cosmetic, and meant to serve this idea that we all need to be ageless or very young, even
yeah,
not even like not aging, but like regressing in age and always looking younger.
yeah. And I think the kind of final argument in this piece was that the reason this is happening now, even though they say that this has probably been going on for like 10, 20 years,
Yeah.
is pornography and people
Oh
having
yeah,
more access
absolutely.
to these vulvas that look like they are super puffed and hairless. So like hair removal practice is really changing
Yes.
the way we perceive the vulva and changing the way we perceive the normal vulva to look.
I have a family member who's in women's studies, and we were talking about just like hair removal in general, and I think the reason that there is not a lot of pubic hair in pornography is because it is a depiction of youth, right? It's all about this
Mm,
obsession with youth. People shave their legs because they want to look younger. People remove pubic hair because it's associated with a younger age when you didn't have pubic hair, which to me is like kind of yuck. Like, why
right.
are we sexualizing such a young age? That's like problematic on a lot of levels, I think.
Absolutely. Yeah.
Yeah.
Um,
Yeah.
when I was kind of Googling around label puffing, what did strike me, and this is sort of like a segue into the conversation around vulva and vagina and labia, etc. is that I would go onto actual like doctor websites, and the terms they use for different anatomical parts of the vulva, it was all over the place.
All over the
All over the
place.
place. They were calling it vaginal filler when it wasn't even vaginal filler. It was labia
No,
majora filler, and it was all over the place. And I think this is a
it's
huge
so
problem.
cringy.
So
Yeah.
moving on to the next segment, I want to talk about accurate genital terminology, which is a huge
Yeah.
problem. And I think it's even bigger because I've noticed from my own social media presence, especially on TikTok, that there is a lot of censoring of the word vulva. And it's like we're not allowed to say it. I don't know what we're supposed to use. But we have a good amount of data research out there suggesting that using the correct terms is very important for many different reasons. Do you want to
Yeah. I
introduce
mean,
this?
it's
Yeah.
well, and for people who are like listening who maybe don't have as much familiarity, vulva is the external female genitalia or the genitals of patients that are sort of usually assigned female sex at birth, and they have and it has like all these amazing functions: the labia minora, the labia majora, the clitoris, the mons pubis, where the most of the pubic hair is. Those are all parts of the vulva, and the perineum, this strip of tissue between the vagina and the anus. And so but each of those parts has different like skin conditions, and maybe you can talk a little bit about this, that can affect it. And so if patients don't know the right anatomy, they can't even tell you what's going on with their own body because they haven't had a chance to know what they're talking about. Like they'll say my vagina is itchy, and then they'll
Mm-hmm.
get prescribed at urgent care yeast medication or medication for bacterial vaginosis, but in fact they have external vulvar itching and raging lichen sclerosis, and they haven't been able to localize the problem. And it's a problem for providers and for patients, I think.
Totally. And I think this is further instilled in kind of everywhere we are, even kind of like kids at school are not really taught the
Yes.
correct terminology to talk
Yes.
about their genitals. Um, and then when I have older patients who come in who I say vulva and they're like, what is that? What are you talking about?
Yeah.
And
Yeah.
yeah,
I have younger patients
younger
too. I mean,
patients
it's not
too,
something we
younger
learn in
patients
school.
too,
Yeah.
younger
I mean, it
patients
was,
too. Totally.
yes.
There was
Yeah.
an article that was recently published in Pediatric Dermatology, and it was called Vulva, Not Private Part, The Importance of Accurate Genital Terminology. And it's really looking at how important it is to correctly label external genitalia, especially female genitalia, in pediatric populations. Um, and one of the main reasons is that this fosters healthier attitudes and better communication about health, which I think is very important,
Yes.
especially in this age when we're all. Uh, I think lay people are just better versed in their own bodies to some extent, so giving them the
Yeah.
language to fully
Yeah.
engage with that.
It's kind of a double-edged sword. Like on the one hand, there are better and more plentiful information sources, but on the other hand,
Yeah.
it's balanced out by dis and misinformation. And so you just like we have to point people in the right direction.
So I think just highlighting that the vagina is on the inside and the vulva is on the outside.
Yes.
Very easy, very easy. And
Yes.
I think we
And
go ahead.
oh, no, no. I was just going to say, like, where I struggle, and one of the hardest things I think is the vestibule,
Mm.
because it's the opening of the vulva, technically part of the vulva, but it's inside the labia minora. So when I'm trying to get patients to put medication there, I'm like, you got to go to the first knuckle on your finger to actually get it to the vestibule, because that is where all of the like hormone receptors are that make your natural lubrication, and that most of the slipperiness of lubrication comes from that area.
Hmm.
So yeah, that one is like a tricky one because it's like this in between zone. But just like a house has a vestibule is the transition from the outside to the inside, the vestibule is the transition from the external vulva into the vagina.
And as a physician, as a doctor who treats a lot of vulvar disease and likes to kind of give people maybe some hot tips when it comes to providing this kind of care, for me, what I found very helpful is going through the anatomy with the patient with a mirror. Just like
Totally.
invaluable, going through the different locations, especially
Yeah.
pointing out
100%.
where medication needs to go. I'm not so much of like I haven't really done. I know some physicians give their patients like little diagrams. I don't really do that. Do you do that? I feel like maybe I could, but I don't.
I do both.
Okay.
So I will say, like where I introduce the mirror depends on the patient's history. Like if they have a really, really significant history of like either medical or physical, like sexual trauma,
Mm,
then I give them the mirror right away so that they can see where I'm going before I even go there. And I think that is incredibly helpful. And then I feel like the whole exam is like a tour of like these are here I'm touching your labia, here I'm touching your the prepuce of the clitoris, the hood over the clitoris. And so I definitely use the mirror that way. I also will just use it as like a quick tour at the end for patients who are a little more comfortable for the exam. I'll be like, hey, let's just either put you up on a screen or put up a mirror so that you can see. But then afterwards, I have patients get dressed, and at every new visit, we go through with a diagram. So
hmm.
it's a little bit of both. But I have the luxury of a pretty long first visit
Yeah.
with patients, so
Yeah.
so it's always, I feel like patients remember things better with pants on, it's just
That's true.
nicer.
That's
So,
true. Um,
that's when we like kind of map out a plan. And, like, for example, if a patient has pudendal neuralgia, like a nerve problem, then we can talk about different therapeutic options and we don't have to do it while they're like naked on the table.
yeah. Having clothes on definitely makes people a little more comfortable, I think.
Yeah. Yeah.
Um, okay. So, the last segment, I thought we could have be like a medical question box where
Yes.
we are fielding questions from the wider audience out there.
Yes.
And one, I get a number of questions on my Instagram that I don't have the time to answer, but some of
Yeah.
them are really good. And I think one of the questions I get asked a lot, and I get this in from my patients who are like messaging me on my portal too, um, is about alternative treatments for lichen sclerosis. So
Yes.
typically, kind of first line treatment, ultra potent topical steroid. Most patients will respond pretty well to that treatment strategy.
Hmm.
Um, but there are some patients who don't respond so well, and they are curious about um, other treatment options. So I guess I get asked about two. One of them is the platelet-rich plasma injection,
Yep.
which I think you have some experience with. Wait, did you do that study with
I
Dr.
don't
Goldstein?
know. Our practice did, there was a branded version of this. And I haven't looked as much into it, but I know that we did the trial in our practice called O-Shot, which
Right.
is like
Oh, okay. Okay.
yeah, yeah, like kind of a version of that. But yeah, I mean, I think that didn't show benefit in our lichen sclerosis patients when it was done as a really well designed study, a randomized control trial.
Hmm.
A lot of the time, these platelet rich plasma protocols are done without a control. So,
Right.
there's a huge placebo effect.
Yeah.
And the other thing is that they've a lot of times been done in practices where people pay a lot of money for the treatments. And I think when you're paying a lot of money for treatment, the placebo effect can be stronger because you're biased to think that you spent your money wisely, right?
Yeah.
It's sad but true, but they're expensive, things that people get told to do a lot. And I just don't think for lichen sclerosis they have a proven benefit. There are some, like, again, there's these like smaller studies that are marginal in terms of like design a lot of times that show some benefit, but I
Hmm.
don't think there's been good RCTs that show for LS that it's helpful.
Yeah. So just like a tiny bit of background
Oh yeah.
on platelet-rich plasma.
Yeah.
So essentially, this is how do they do this? I think they usually I did read some papers where they took like cord blood, PRP,
Yeah.
but most of the time it's autologous. So they will draw your
Yeah.
blood and then they will separate the blood,
Centrifuge.
centrifuge, separate it into serum and plasma, and then the plasma has all these platelets in it. And platelets are the blood cells that cause clotting, so they stop you from bleeding. But they also have a lot of growth factors in there that theoretically can stimulate growth of, say, collagen um, in the skin.
Right.
And they have lots of cytokines, different kinds of proteins that apparently can initiate tissue repair and produce new connective tissue and
Yeah.
basically revascularize tissue that has lost its blood supply. That's the
Yeah.
theoretical basis. So you
That's
can
the
see how
idea.
in
Yeah.
lichen sclerosis, where you have a fibrosing dermatosis, that this might be helpful. So
Yeah. You get a
theoretically, there's
lot
a
more
potential.
fibroblast formation and collagen deposition. And the idea is to like put something in the tissue that will make less of that happen so that you
Right.
don't get the scarring and the changes, right?
Right. So a lot of
Yeah,
the
I just think I you know, oh, you go ahead.
no, so a lot of the papers I have looked at this and the talks I have read about it is that this is not a primary treatment. This is an adjunctive treatment to patients who are
Sure.
already being treated with first line therapy with topical steroids. So none of the papers I have looked at were treating patients just with PRP. So it may have been people
Sure.
who had done first line therapy and then didn't respond accordingly, and then they were treated with PRP. And they were
Yeah.
also in some of these papers using topical steroids alongside PRP
Lord.
injections,
Yeah.
right? So it's difficult to tease out what's doing what, but a lot, in many of these papers, they're claiming that there is a um, statistic benefit. What am I trying to say? Statistically significant
Yes, definitely.
response.
Yeah.
And it's
Yeah.
mostly in symptoms. So, like itching or
Yeah.
pain, discomfort. Those are the kinds of measures they're looking at. And they are finding some improvement. But again, you're absolutely right. None of these are very well designed trials. I feel like at least to some degree, I think it was in the paper that you were on that even just the act of like injecting um, anything, like even just saline into this vulvar skin, will it that kind of minor trauma? And I mean, that's the whole basis of
Yeah.
something like CO2 laser, right? That you're causing minor
Yeah.
trauma, and that's
Or even a trigger point injection, right? Like for people who have like sort of muscular pain, a little saline needle can do a lot,
yeah,
actually. I mean, and I think that also, I think that there have been papers that show that even like a greasy barrier ointment plain without any kind of other pharmaceutical activity can do a lot for lichen sclerosis by
right.
like hydrating fibroblasts and preventing cytokine release. And so it's hard to tease all that
It's
out.
hard to tease it out. One of the other takeaways I always take from these studies, whether it's PRP or laser, a lot
Hmm.
of the time they are not looking at whether there is an actual objective decrease in inflammation. So we know that when
Yes.
we biopsy skin that's
Yeah.
affected by lichen sclerosis, there's a very classic inflammatory pattern that we see under the microscope. And the goal of our treatment is really to decrease that. Um,
And can you just because you have the pathology background, can you describe what that looks like? I
yeah,
mean, I
so
kind of remember vaguely from my med school days, but I would love to hear you kind of
So,
describe
so
the
what
differences.
we're seeing in lichen sclerosis is interface change or like lichenoid inflammation. So basically, lymphocytes are attacking the dermo-epidermal junction. So you'll see lymphocytes along the edge of where the epidermis is in the dermis, and then in the dermis, you're going to see collagen that's fibrotic or sclerosed. It's kind of like this muted pink, milky collagen. And sometimes beneath that, you'll see a band of lymphocytes as well. So, like a lichenoid band of lymphocytes. And lymphocytes are these white blood cells that normally there is like a baseline amount, but you shouldn't have like a whole band of these cells in the skin. And what this
So
inflammation
it's
is
like there are
causing
two layers of yeah, like two layers of skin, and these immune system cells are in
are
between that
in
are
there.
causing this
So,
thickening.
when I
Yeah.
when I was a resident, the way we and you can also have like thickening of the stratum corneum or hyperkeratosis, and we can see that a
Hmm.
lot and like follicular plugging and those kinds of epidermal changes. And hyperkeratized
Yeah.
lichen sclerosis we see quite commonly. So the way that I think of
Yeah.
it is like red, white, and blue. So you have that red kind of hyperkeratosis, and then that white sort of sclerosis, and then the blue lymphocyte band. So that's what you're seeing.
And
So theoretically, I guess if you're biopsying diseased skin, you're going to see that. And then ultimately, you want to see a decrease in that post treatment
sure.
with whatever you've done.
Yeah.
And a lot of these studies, I think they probably help with symptoms, but the question is, are they actually helping with inflammation? And the reason we worry about inflammation is that we know chronic inflammation in the skin can lead to neoplastic changes or atypia,
Cancer. Right.
so cancer.
Cancer.
So
Yeah.
that's what we're worried about, really. So that's
So
my
if you're
question
not
here.
cool,
Yeah,
right. So if you're not cooling off that immune reaction and able to see that it's better under the microscope, we worry that then down the line you're not reducing people's risk for cancer in the presence of these conditions. And
exactly.
yeah, yeah. And
So
carrot, when you're talking about hyperkeratosis, that's just extra deposition of keratin, like the protein that is in like your hair and nails, right? So the skin
so
becomes,
yeah, so like hyperkeratosis, so that's the as our skin sort of matures from the basal layer of the epidermis. So you know that the acronym that I always used when I was like a path resident was what was now I'm gonna like blank on
well,
it.
I don't
So
know if you don't know.
there's like um the stratum corneum, the stratum
Yeah.
granulosum. It's like California girls love string bikinis. I think
Oh, fun.
anyway, so as the epidermis matures, the epithelium, the keratinocytes, they lose their nucleus and then they become like skin flakes or denucleated keratinocytes, and they form that scale that you see in lichen sclerosis, and you can have
Yeah.
that thickening of the scale. So it's really just like the top layer that's
Yeah.
denucleated, and it's just like the ones that get sloughed off in normal skin.
Yeah, but they're just stuck. And it makes it hard to get the drug down to the
Yeah, so it
bottom
makes
layer
it
of the
hard to get
skin
the medicine into the skin.
where the
Um,
problem is, right? Because the immune system problem is way down below that layer of skin. And if you
yeah,
have a
so
bunch of,
figuring out like a vehicle that can get there, and then sometimes we use like adjunctive things that can like keratolytic things that break down the keratin protein so that you
yeah,
can better access and have better absorption with the skin.
yeah.
Now someone's going to be like searching my epidermal knowledge. I'm like,
Well,
oh
you're on the
man,
spot.
I'm there. But I think so. You know, my takeaway from PRP is we have a lot more work to be done to determine whether or not this works. It has shown to provide some relief, improvement in
Yes.
symptoms in some patients.
Hmm.
TBD on this one. I
Yeah,
definitely
I think that your point about it being a potential adjunctive therapy is so important. Like
adjunctive,
it isn't a
adjunctive.
substitute for good base therapy. Yeah.
And
Yeah.
I know there's a lot of hesitation with super potent topical steroids, and people are always looking for alternatives because they worry about skin atrophy from steroids, etc., potential systemic absorption. You have it, but we're not really quite there. So I wouldn't
Mhm.
recommend this as first line. Um, and the cost is also, can be prohibitive
Yeah.
because you got to draw the blood, you got to prepare the PRP, and then someone's got to inject it. Insurance is not going to cover this. So we're talking, and people usually don't have just one session. They have multiple sessions kind of spread apart. So there is also a cost consideration here.
Right.
Um,
And the way that it gets to be covered by insurance would be one of these high quality studies. And it just hasn't happened because probably of how prohibitively costly it would be, especially one that would take into account keeping people on like sort of standard of care therapy and then adding it on top of it. Then you have to have a ton of people to really figure out what the difference is.
yeah, and I now we're going to insurance company rant, but I feel like insurance companies are not really about like improving quality of life here to that extent. You know, they're like, is this medically necessary?
Yeah.
And I know PRP injections, you know, there's like some data out there that it helps with like hair loss, and it's not covered. It's not covered in hair loss. Like
No.
you're paying out of pocket for that too. But again, that
Yeah.
data is sort of like
Yeah.
all over the place
I mean,
as
if you can
well.
get like my understanding is if you can do the RCT and use that to the randomized control trial, the really good design study, and use it to get FDA approval. Once you get FDA approval, then you have more ammunition to get a drug company or to get an insurance company to
Okay,
cover
for
it.
it. Yeah.
But like they're not without FDA approval, then they're not going to even look at it. That's the same reason we like can't get testosterone for women covered. You know, like I'll have patients who are on it for various indications, and there's no they'll call and ask if it can be if we can write an appeal or something, and there's no hope of coverage. The only place that it's covered is in Australia by their like
Oh,
insurance
interesting.
system. There is topical
Well,
testosterone for women
wow.
there, but
I did not know
yeah.
that. I mean, that's
So I
funny.
always joke you got to go down under to fix your down under potentially. Some
Well,
jokes.
I think we've come to the end of what we were planning
Yes.
on talking about. Um,
Yeah.
so now do we ask for like feedback?
Yeah, I mean, I just think that the takeaway is like, okay, this is a new thing. We're going to see what it's like. We'll
Yeah.
try to do each time like kind of a pop culture thing that's happening,
Yeah.
a scholarly thing that's happening, and answer some questions. So if you have questions, submit them.
Yeah.
We're happy to like talk about them, or ideas for pop culture things that you're curious about. Would love to hear from people what they're interested in, because I'm not as attuned, what the kids these days are are doing. I
Um,
know a couple of slang terms from my 9-year-old, and that's about it.
yeah. I kind of I'm not that in tune either. I mean, I've never had a patient ask me about labial puffing. They had a dermatologist in this article be like, "Oh, every week I get two or three
No,
people."
I
I'm like,
haven't.
"No."
But two people in the last week have asked about labial resorption and been like called in frantically. Or like longtime patients who were doing fine who are
Yeah.
like, I just found out that there are going to be anatomic changes as I age.
Yeah.
So it's a hot topic on
Yeah.
the socials for
Definitely.
sure. Yeah.
Okay. And then I guess I'm going to plug my Instagram.
Yes, you should.
What is it? Is at Dr. Hawks.
Oh my gosh.
At
I
Dr.
gotta look.
Hawks, COCKS, and I'm also on TikTok, Dr. Vulva Derm. You can find me there, at least for the foreseeable future. I don't know what's going to happen with that.
Yeah, and I am not on TikTok, but I am Dr. Kylie Moss, which is ChaileeMoss on Instagram, and I am the same on YouTube and Reddit.
Oh, I didn't know you had a YouTube.
Yeah, I, I mean, no one else does either.
No.
Let me tell you. Yeah,
Well,
it's a well-kept secret.
yeah, maybe not for long. Maybe the cat is
Yeah,
out of the bag.
yeah,
The
yeah,
proverbial cat has left the bag. Okay.
yeah.
Well, that's a wrap. Thanks for
All
listening.
right.